So my name's Dr. Jeff Gerber. I'm a family doctor from Denver, Colorado. And as we like to say, real food is medicine. Now I tell you, it's fun traveling halfway around the world to give a couple of talks, but that's not really why we came. This is why we came. So that's my daughter Courtney and myself 3 days ago up on the reef, having a blast. And that's Courtney bonding with the sea turtle. So I'd like to talk to you about diabetes, heart disease, and navigating through the muddy waters when it comes to cardiovascular risk assessment. I'd like to introduce you to a few people. So that's me in the center, and then to the right is my engineering problem-solving colleague, Ivor Cummins. And he convinced us last year to visit the gentleman on the left of the screen, and that's Dr. Joseph Kraft, who is now 96. And he is a retired pathologist, and he spent a career studying insulin metabolism. And he noted that there was a strong connection between diabetes and heart disease, so much so that he said that those with cardiovascular disease not identified with diabetes are simply undiagnosed. And I'd like to explain to you why I think he said this. So Dr. Kraft was the chief of pathology and nuclear medicine at St. Joseph Hospital in Chicago for over 35 years. And during that career, he devised a test that we now call the 5-hour insulin assay. And he did the test in over 16,000 people. He also personally done 3,000 autopsies, and he had collaborated with other professionals looking for the root causes of chronic disease. Now, Dr. Kraft was well published in the literature, but it wasn't until he retired that he wrote a book called Diabetes Epidemic and You, and I wish that every healthcare professional would read this. And this book really details his career. It talks about the insulin assay and how it relates to cardiovascular disease. And we'll talk a little bit about that. So what Dr. Kraft had set out to do was to demonstrate that the standard methods to diagnose diabetes and prediabetes were inferior. And by those standard methods, we're talking about blood glucose measurements. Now that could be a fasting blood glucose, or after a 2-hour glucose challenge, or after an HbA1c test. And what he demonstrated is that hyperglycemia is a late finding. Now I'm just curious, how many type 1s do we have in the room here? Just a few. So we just heard that talk about the type 1s, and this is slightly a different topic because we're talking about using fasting blood sugar as a screening tool, whereas in type 1s, it's an absolutely great way to monitor type control. So just so you understand the distinction, hyperglycemia is a late finding and not a good tool for screening. So the Kraft insulin assay was based on the radioimmunoassay that was being developed in the 1950s, the late 1950s. And this was a method to measure low concentrations of substances in the blood. In this case, we're measuring insulin. And at the time, they knew that type 2 diabetes, what they called back then adult onset diabetes, was a disease of insulin excess, but nobody had quantitated it. That's what Dr. Kraft set out to do, and to also create this gold standard. So the test he had performed in the book, he reported 14,000 subjects. And it's similar to a glucose challenge where you give 75 grams or 100 grams of glucose, but what was different is not only did you measure glucose, you measured insulin over a 5-hour period of time and at intervals in between. And when Dr. Kraft looked at the data, he saw that it clustered into 5 distinct patterns. There was pattern 1 that he called normal, and then there was pattern 5 that he called low. And then there were these 3 patterns in between that he referred to as hyperinsulinemia, or diabetes in situ. And indeed, what Dr. Kraft had created was a new method to diagnose prediabetes and diabetes, but also to diagnose diabetes at its very earliest stage. And so let's look at the patterns briefly. So here's pattern 1. And you can see that insulin is low, let's say less than 5 microunits, and it never peaks above 60 microunits. And now what we're going to do is superimpose the 3 patterns of hyperinsulinemia. And you can see that pattern 2 and 3 in the yellow and the orange are similar in that they have a low or normal fasting insulin. Pattern 4 is different than those because the fasting insulin actually goes high, and then the 2-hour shoots up to almost 200 microunits. And so what he demonstrated was indeed diabetes or diabetes in situ were diseases of insulin excess. Now, from a clinical standpoint, I'm not necessarily interested in the specific patterns of hyperinsulinemia. I just want to know that we have a problem of insulin. And so what Catherine Crofts from Auckland, New Zealand did was her PhD research and her thesis based on the Kraft data, and she simplified this for clinical use. Now, I just met with Catherine for the first time last week when I visited Auckland. That was an awesome experience, and she's brilliant. And so what she basically said is that you can measure a 2-hour insulin. And if it's under 30, you're non-diabetic, and if it's over 40, you have diabetes or diabetes in situ. So this is what we call the pesky pattern 5. So this is the low insulin response. And you'll see why I call it pesky, but there's two situations that are fairly obvious that you would have a low insulin response. Number one, if you're a type 1 diabetic that you never produced insulin in the first place. And the second scenario is when you're what we call a burnt out type 2 diabetic, where your pancreas stops producing insulin. But there's two other situations where we see this low pattern. And the first is when you are fasting, and the second is when you're on a low carb diet. Now, what Dr. Kraft showed back in 1975, if you actually took somebody on a low carb diet and you gave them carbohydrates, you carbohydrate loaded them for a few days before this test, this pattern 5 would revert back to a normal pattern 1 or something else. Now, this doesn't happen to everybody, but we now refer to this as something known as physiologic insulin resistance. Now, some people have argued, well, this pattern 5 that low-carb people are experiencing is representing something bad, as if it's some type of glucose deficiency in the diet or some type of insulin deficiency. But really, what Dr. Kraft demonstrated is this is just a normal physiologic adaptation to being on a low-carb diet. And this is just interesting for us to do in our office because we've done glucose tolerance tests over 2,000 over the last 16 years with and without insulin. So this one gets a little bit technical, but I really wanted to understand how insulin is a better measurement than glucose, so you have to compare the two. And so I looked at Kraft's data and recompiled it and created something called a confusion matrix. So your eyes might glaze over, but this is the confusion matrix. And what it does is it compares one method, in this case hyperinsulinemia, to hyperglycemia. And so on the right of the screen, we can see the positive and negative predictive value. And that tells the individual their likelihood of having a given disease, in this case hyperinsulinemia, based on hyperglycemia. And on the bottom of the screen, we see sensitivity and specificity. And that tells the researcher or the clinician how accurate or valid the test method is, in this case, hyperglycemia. So you run the test, and the result comes back hyperglycemia. You have a high sugar response. Well, the positive predictive value is 97%, and the specificity is 92%, both high numbers. So that tells us if your result returns hyperglycemia, you can be fairly certain that you have hyperinsulinemia. In fact, you don't even have to do the Kraft insulin assay. We're all good. The problem is when the test result returns euglycemia, or a normal glucose response. And you can see the problem is that the negative predictive value is 28% and the sensitivity is 52%. Now, I'd like to simplify that by showing you two pie charts. So this is looking at negative predictive value. And in this situation, all the individuals were euglycemic. They had normal blood sugar based on a fasting blood sugar and our 2-hour glucose tolerance test, but yet 72% of them failed the Kraft insulin assay. That's not very reassuring. And so here we're looking at sensitivity. So we're comparing hyperglycemia to euglycemia. Now, it turns out that hyperglycemia can actually pick up 52% of the abnormals. It's not the best, but it's not bad. But it misses 48% of the individuals that were euglycemic and yet failed the Kraft insulin assay. So this is actually an argument to do more standard glucose tolerance tests in the office, and we do that. And unfortunately, the mainstream doctors just have given up with that, and they just do fasting blood work. And at the end, we'll talk about how you can improve upon the standard glucose tolerance test, both with and without insulin. But the important point here is that, again, hyperglycemia is a late finding. And if you don't test insulin, you're not going to know there's a problem. So the next question, could the Kraft insulin assay predict population risk? Well, let's take a look at that. So there was a study last year that suggested that up to 52% of the population in the US are now pre-diabetic and diabetic. That's a huge number. That's a scary number. Okay, and that number's about right based on standard testing, and they actually did glucose tolerance tests, fasting blood glucose, HbA1c. They did standard testing properly, but of course they didn't measure insulin. Imagine if they measured insulin. We would predict that at least 2/3 of the population would have failed the Kraft insulin assay. The point is, again, if you don't test, you're not going to know there's a problem. So I would like to shift gears and talk about cardiovascular risk and ask the question, is there a diabetes paradox? So some actually say that despite seeing more diabetes and obesity, that there's actually less heart disease. So we have to think about that. And I think since 1995, it's true that we've done a much better job treating the complications of heart disease, thanks to the emergency medical system, the intensive care unit, and modern day procedures in the office. Okay, but that's addressing what we call morbidity and mortality. What we're really looking at is the incidence or the prevalence or occurrence of new disease, and that's a tougher one to get at. Now, it is true that during this period of time, we see that people have cut back on smoking, they've cut back consuming trans fats, but at the same time, we see diabetes and obesity on the rise, so you have to consider all that. Now, one way we can address this question is by looking at something called subclinical cardiovascular disease. And you can do that with imaging of the blood vessel. And we're going to talk at the end about a test called the calcium scan. It's a test that actually sees the disease. It's an amazing test. But when you start to look at studies such as this, you can see that with more diabetes and obesity, there is more heart disease. And that's the whole point of this presentation. So we don't see that there's any diabetes paradox at all. So what did Dr. Kraft have to say about heart disease? Well, he said that atherosclerosis is a metabolic disease, and so you therefore want to focus on diabetes and prediabetes, and if you don't, you're going to miss cardiovascular disease. And then in 1988, a gentleman by the name of Jeffry N comes along and makes headlines for something called the Metabolic Syndrome, and what we more properly call today the Insulin Resistance Syndrome. And he too noted that atherosclerosis was a metabolic disease. And he broke it down into different components, namely glucose intolerance, hyperinsulinemia, just like Dr. Kraft, and most importantly, atherogenic dyslipidemia, where we're now looking at the quality of the cholesterol, not necessarily the quantity. And we measure the quality by looking at ratios of triglyceride to HDL, looking at the particle size, and that was what was important. In fact, they don't even talk about total cholesterol and LDL concentration when we discuss metabolic syndrome. Also, elevated blood pressure and abdominal obesity was involved. Now, it also turns out that the insulin resistance syndrome was associated with many of the other chronic diseases that we see today. And this was fascinating to me when I had first learned about the metabolic syndrome, because it now described the root cause for all of these chronic diseases that we see in modern day society. But it was also frustrating to me, although doctors knew about the metabolic syndrome, they didn't know what to do about it. Why? Because as we see it, it's a nutritional syndrome that you treat with nutrition, specifically a low-carb diet. And you know that low-carb diets haven't been popular. Doctors are looking for medication. Now, metformin may address this, but it doesn't really get at the root cause. And even Dr. Kraft and Jerry Raven wouldn't touch that giant elephant in the room, the nutritional aspect, because they didn't want to upset their colleagues. They just focused on their methodology. So as I see it, they missed a golden opportunity. But you know what? It's our turn. Yes. So it's well established in the medical literature that there's a strong link between diabetes and heart disease. But when it comes to clinical medicine, not so fast. And unfortunately, I see this all the time. On the one side, we have diabetics that don't know that they have heart disease. And the other side, we have heart patients that don't know that they're diabetic. And even worse, their doctors are clueless. And the question is, why is there such a disconnect? Well, welcome to the Framingham distraction. Yes, that's Framingham, Massachusetts, where back in the 1940s, they tracked the population over decades to see which ones had heart attacks and which ones didn't. And then they followed other things that seemed to be negatively associated, and they called them risk factors. And we know them today as bad cholesterol, smoking, high blood pressure, diabetes. And since the original work, they've come up with different guidelines, tools, and risk calculators, all with a central theme, to lower that bad cholesterol. And we're all familiar with this, and this is where the problem is. You go to the doctor's office, and he checks your cholesterol, and he gives you advice to lower the bad cholesterol, either with a low-fat, low-calorie diet and/or medication. But what this approach doesn't address is metabolic disease, hormonal dysregulation, and it doesn't properly measure diabetes. This approach misses the mark. So here's your Framingham risk score. You ask a couple of these questions, and you take a guess whether you're going to live or die. It's a statistical guess based on epidemiology, and it's very hard for any of this to apply to the individual. Again, as I said, it's really heavily cholesterol weighted. Some people argue, well, we are measuring metabolic disease because, you know, diabetes is listed there. Yeah, but again, they emphasize cholesterol, they de-emphasize diabetes, they don't measure blood sugar properly, they don't measure insulin properly. These are the muddy waters of Framingham. So what's so important about lowering cholesterol anyway? Medical doctrine tells us that high cholesterol is bad and requires remedy, as if to imply that cholesterol is innately toxic. Well, what are the mechanisms to support this? Well, they've talked about decades that there's a problem between concentration gradients of cholesterol in the blood and cholesterol in the blood vessel wall. In recent years, they said, no, it's inflammation, that's what the problem is. But overall, we find that these mechanisms remain elusive. So what about the studies to support this? So the diet heart hypothesis tells us to reduce saturated fat in the diet. But as we know, that has been mostly unproven. What about medication? Well, you can tell patients who are free of heart disease to take a statin, but the benefit is actually very small indeed. And so we don't recommend that anymore to our patients. It is important to recognize that there is a small mortality benefit to giving a statin in patients that have pre-existing heart disease, what we call secondary prevention. So you have to keep that in mind, but overall, we are not impressed. So we can further debunk the lipid hypothesis by looking at some other studies, and there's several. I just have two listed. And they're associational studies, but they can challenge a null hypothesis, or the default hypothesis, in this case, the lipid hypothesis. So in 2009, they looked at almost 140,000 patients that were hospitalized with acute cardiac events. And then they looked at their cholesterol. And what they found was that 3/4 of them were actually at the Framingham cholesterol goal. So the question is, if they were at goal, what were they doing in the hospital having heart attacks? Makes you wonder. We have another study in 2015 that looked at large populations of elderly people, and they looked at their cholesterol. And what they found is that the ones who had higher cholesterol actually lived longer. Go figure. So let's compare all that to the mechanisms for metabolic disease and hormonal dysregulation. And I refer to this as the root cause diagram. It's very similar to the metabolic syndrome, and you can see that the liver's involved, the fat cells are involved, the blood is involved, and we see this atherogenic dyslipidemia. So we put this all together, and we call this metabolic mayhem. And downstream, it leads to things such as inflammation, oxidative stress, and advanced glycation, which is ultimately damaging to the blood vessel wall. And as a result, we see atherosclerosis. And it's important to understand that atherosclerosis is the body's attempt trying to repair the damage. And this reminds me of the plumber. So your pipes are leaking, what do? You call the plumber, he comes to your house, he wraps some tape around the problem, and most importantly, you give him some money. I'm not referring to the cardiologist now, am I? But what didn't he do? He didn't check the water pressure, he didn't check the minerals in the water, he didn't address the root causes. And so you see it's the same with atherosclerosis. Now, what's the role of that bad cholesterol? Well, maybe it's not that cholesterol is innately toxic, but rather it's there as a consequence of all this other stuff. Makes sense. So do we have studies to support these mechanisms? Can we compare diabetes and heart disease risk? Can we look at glucose and insulin? Can we compare insulin to cholesterol? We have a couple studies to show you. So this is the Helsinki policeman's trial. It's from the 1970s. And they tracked the individuals over the years, and then they looked at their insulin. What's neat is that they measured 2-hour insulin. So they measured insulin properly. And so we have low insulin and high insulin group. And so this is the low insulin group. At 5 years, their risk of having a cardiac event was 1%. And then we can look at the high insulin group. At 5 years, their risk went up to 9%. To the untrained eye, that doesn't seem very impressive. But actually, that's huge. That's a ninefold difference, almost an order of magnitude, what we call a 10 times difference. That's actually a huge difference. And so now let's compare this to what generally happens to cholesterol over this time period. So we have low cholesterol and high cholesterol group. So the low cholesterol group at 5 years, the risk was 3%. And then we have the high cholesterol group. What do you think happens to their risk when the cholesterol is high? Does it go up? Does it go down? Does it stay the same? Well, the risk went up, but just by 1%. That's not even 1.5 times. So if you're comparing 9 times to 1.5 times, that's a huge difference. It's like the elephant versus the mouse. And the elephant represents insulin, and the mouse represents bad cholesterol. And the elephant will predict risk much better every single time. So here's some other studies that more properly look at insulin and glucose, and virtually all of them, insulin and glucose significantly correlate with cardiovascular risk, whereas the bad cholesterol doesn't seem to correlate. These are case control studies, by the way, and the statin industry actually hate them because it doesn't support their medications. But you know, there are situations where we do prescribe it. But if you actually look at, there's 3 studies there in the red that show that there's an inverse relationship between cholesterol and heart disease, meaning that when the cholesterol went down, the heart disease risk went up. And the authors have to be careful when they present data like that that kind of contradicts everything else. So future research, we want to further compare insulin to bad cholesterol. We'd like to see interventional food trials looking at low carb versus low fat and heart disease. We want to track subclinical disease with scans such as the calcium scan, and we'll talk about that, and measure cardiovascular outcomes. But the bottom line, it's the insulin stupid. And I'm talking about the good doctor there, my doctor colleague. To recognize that atherosclerosis is a symptom of diabetes, and you therefore focus on metabolic disease, hormonal dysregulation, and insulin, and to realize that many are at risk. Again, it is a nutritional syndrome. We're not treating it with medication. We're treating it with diet. And it's somewhat frustrating because, you know, in the US, how are we going to convince doctors that they're going to make money telling people how to eat better? It's sad but true. So What is the diet and lifestyle advice that we're going to recommend to prevent those arteries from being clogged? So the advice should be based on metabolic disease and what drives it. What drives hormonal dysregulation and insulin? So carbohydrates is the first culprit, then protein, and in this context, natural fats, saturated fats are metabolically neutral. And this advice should probably be for the majority of the population because we're saying that at least 2/3 of the population have this problem, right? And so this is the advice that we give our patients. That low carb is best. We cut sugar, grains, starch. Fiber is okay. We eliminate processed food, especially the highly atherogenic industrial vegetable oils, canola, corn, and soy. And we replace it with monounsaturated fats and saturated fats. If this is working right, people are going to eat less. And I think it's important that the low-carb diet includes a message of eating less. But it happens as a consequence. Movement and activity are important, smoking cessation, sunlight, the list goes on. There's lots of tweaks, but we don't have time to discuss. Clinical assessment, I wish that everybody in the healthcare field would read Dr. Kraft's work, would read Catherine Croft's PhD thesis that talks all about the importance of measuring insulin. To understand that, again, standard methods of measuring blood sugar are a late finding, and you can't rely on them. Again, I think that more people should do the glucose tolerance test. We have improved the sensitivity by including a 1-hour glucose. We can do insulin. We can measure fasting insulin, perhaps under 5 microunits is a good number. And we do the Catherine Croft method of insulin assay. We measure the 2-hour level. Less than 30, you're okay. Above 40, you have a problem. And this testing is probably for the standard population. So if you're on a low-carb diet, you don't necessarily have to do this Kraft insulin assay. You have to consider whether you want a carbohydrate load or not. But again, in the general population, the insulin assay can be really beneficial. And you can measure inflammatory markers. We still measure lipids, but we're looking at quality, not quantity. And we can do standard body fat, waist to height measurements. So lastly, we're going to talk about cardiovascular imaging. And there's many tools and many methods, but we're looking for ones that are non-invasive and relatively inexpensive. And the one at the bottom is the coronary artery calcium score that we prefer. And you have to understand that this gives us some historical information because it takes a lifetime to develop plaque. So we have to thank some of the founding fathers of this technology that dates back some 30 years. So there's one physicist and the rest of them are all cardiologists. And you might recognize Arthur Agustin on the bottom left, who was famous also for the South Beach diet. So this guy was way ahead of his time. And so these are 2 images of 2 different people of the calcium scan or the CT scan of the heart, where we're actually now seeing the disease, we're visualizing the disease. So how this technology works, it's a high-speed CAT scan, and it's available everywhere in Australia as far as I understand.
Free pass.
Yeah.
Free.
Cool. And so it takes a high-speed image of the heart and in different slices, and it can see the calcium in the blood vessel. It adds it up, and then you get a score. Now, as atherosclerosis develops, first it's soft plaque, and as it's hardening, the calcium builds up, and you can see the calcium and then measure it. So the individual on the right has a very high calcium score. You can see that area bright white represents the left anterior descending artery, what we call the Widowmaker artery. And David Bobbitt has produced a wonderful documentary called The Widowmaker Movie, and it talks all about the calcium scan, and I recommend that you watch it. But we might say that this individual has a high scan in the 1,000 range, okay? We don't have much history on that person, but on the left of the screen, we do have some history on that individual. So that one has been on a low-carb, high-fat diet for over 15 years, is from the United States, and initially lost 40 pounds, so you can convert that, and has remained on a low-carb, high-fat diet, a whole foods diet, ever since. And you can see that there's no calcium in the left anterior descending artery, and that is the same throughout the entire sequence. Now that's important because that person happens to be me. So I have a perfect calcium score of 0. That's amazing, right? I think Rod Taylor has a perfect calcium score of 0. How many people have had this scan? Just a few. Okay. But what's really important is that because I have a perfect score of 0, my risk of having a cardiovascular event in the next 10 years is less than 2%. One study gives me a 15-year warranty that I won't drop dead from a heart attack. Now, I hope I'm not jinxing myself and that this stays true. But am I genetically blessed? Well, I do have diabetes and heart disease in my family. I do have some favorable genetic markers, but perhaps it's everything that I've been doing right that gives me a score of 0, and I need to keep it that way. So I can tell you that the studies show that this is reproducible and quantifiable. And here's just a smattering of them, and you can see that as your score goes from 0 to 1,000, your risk goes up by an order of magnitude. This has been done in literally hundreds of thousands of people. And although we call calcium a risk factor, it really isn't a risk factor. Calcium is seeing the disease. Plaque has calcium. Calcium is plaque. They're one and the same. And this summarizes a calcium score. So you can have a low risk as a score of 0. Your risk 10-year event rate is less than 2% versus a high score of 1,000 where your event rate goes up 37 times. It's beyond an order of magnitude in terms of difference. Now, as you can imagine, the calcium score blows away Framingham risk. And we can illustrate. So we can look at the middle risk individuals. And Framingham would say their 10-year event rate risk is 10%. Well, are they all at 10%? Well, let's look at the calcium scan. Well, no. So we can see that we have ones who have a very low risk. In fact, they have a 0 score. We have true middle risk, and then we have the true high risk where their risk goes up 36 times. And again, this just illustrates how Framingham takes a guess, and the calcium scan sees the disease itself. So what if you get a calcium scan and the first one says high? Are you doomed? Well, it depends. And this is where you want to try to stabilize your calcium. And let me illustrate. So we have individuals here who started out with a high score, up to 1,000. And we follow them over 3.5 years. This is real data. And we define progression of calcium as greater than 15% a year. So what happens to their risk? Well, they have a 50-50 chance of having a major cardiovascular event. Uh-oh. That's a problem. But then let's look at these individuals. They also started with a high score of 1,000. But they stabilized their calcium, and that's defined as progression less than 15% a year. And when you go out 6 years, guess what? Their risk was only 3%. That's almost equivalent to having a 0 calcium score. So the point is you want to stabilize your calcium. And you can do this scan every 2 to 3 years, maybe sooner. If you're really concerned, there is a little bit of radiation to consider. And you need to take action. You want to address this with diet and lifestyle, and perhaps in the ones that have really, really high calcium scores, you might want to consider medication. And that includes statins, by the way. So just a few more points about the calcium scan. It's now in the 2013 guidelines, but hardly any healthcare professionals know about it. We use it as a wonderful tool to promote health. And we think that other healthcare professionals, GPs and the likes, should be offering this test methods to patients to get them to take proper action. When the test is used properly, it's not going to lead to more unnecessary testing. It's relatively inexpensive and non-invasive, just a small amount of radiation. It's true that it doesn't detect soft plaque, but it doesn't really matter. It is the mathematics that predict the risk. It's been done in over hundreds of thousands of patients. And lastly, the calcium score is obligatory in all US presidents and astronauts. So why isn't it available to all of us? Like our insurance companies don't pay for this test today. You have to pay out of pocket, although the price is dropping. So I hope that the muddy waters are clearing when it comes to cardiovascular risk assessment. We talked about the power of the calcium scan. We talked about the root cause and how to properly take action. And so when you and your doctor are grabbing for the Framingham risk calculator, it's best to think about diabetes, metabolic disease, and hormonal dysregulation, because what's most important is to recognize that diabetes is a vascular disease. Thank you for your time.